Welcome to the InTouch Health webinar series. This is Rachel Gonzalez, and I'll be your host for the webinar. Today we are featuring Jordana Bernard of InTouch Health, and she will be presenting on telehealth policy and legislation. Jordana Bernard is Director, Policy and Public Affairs at InTouch Health. In this role, she executes strategies for key telemedicine advocacy and policy initiatives. Prior to joining InTouch Health, Ms. Bernard served as Chief Program Officer at the American Telemedicine Association. Her background spans multiple senior management positions focused within the healthcare industry, including working as an independent consultant when she became actively involved in telemedicine and developed and implemented the first telemedicine network to deliver clinical services within the federal prison system. Ms. Bernard earned an MBA from Marymount University and a Bachelor's of Science in Biomedical Engineering from Boston University. We'll begin our webinar shortly, but first, some notices. You all have been auto-muted. If not, please make sure you mute yourself. And at the bottom of your audience console are multiple application widgets you can use. If you have any technical difficulty, please click the Help widget. It's the one with a question mark icon, and it covers common technical issues. You can expand the slide area by clicking on the Maximize icon on the top right, or by dragging the bottom right corner of the slide area. During the webinar, you will be able to enter questions in the Q&A widget. Questions will be answered at the conclusion of the presentation, so feel free to ask questions at any point throughout the webinar. If a fuller answer is needed or we run out of time, questions will be answered later through email. The webinar is going to be recorded, and a copy will be available for you after this live presentation. The webinar should last about 60 minutes with time for question and answers at the end. And now, without further ado, here's Jordana.
Great. Thank you so much, Rachel. Hello, everyone. We really appreciate you taking your time to join us today for this federal telehealth legislative and regulatory update. We'll get started talking a bit about how we got to where we are today. Then we'll talk about what's happening currently. And finally, we'll talk about where we may be headed and opportunities to advance the federal policy agenda. By way of background, it was the Social Security Act that created the Medicare insurance program in 1965. This program is administered by CMS and provides health care benefits for seniors who are 65 years of age and older, also for younger disabled populations, and for people with end-stage renal disease. Today, Medicare serves approximately 58 million people across the nation, and the number of enrollees is projected to grow to 60 million by the end of the year and to nearly 80 million by the year 2030. Medicare beneficiaries enroll in fee-for-service or traditional reimbursement programs, which are covered under the physician fee schedule, and value-based payment models, including Medicare Advantage plans and accountable care organizations. In the year 2000, Section 1834M was added to the Social Security Act, and in 2001, CMS implemented it. This provision provided the basic telehealth coverage in fee-for-service, and it set the stage for Medicare's restrictive policies around coverage and reimbursement that are still in place today. Essentially, 1834M restricts coverage of telehealth services to real-time interactive video, to an originating site located in a rural area, to a limited set of authorized facilities or originating sites, by a limited set of authorized distant site practitioners, and for a limited set of telehealth services with approved procedure codes. The law also set up an annual process to add telehealth services to the list, and every year a few new payment codes get added. In 2016, there were 82 CPT or HCPCS codes for telehealth. This went up to 89 in 2017, and in 2018 we have 96 approved codes. Under Medicare, the most common claims that have been submitted to date for the use of telehealth have concentrated around evaluation and management or other outpatient and mental health visits. And in large part, the reimbursement restrictions imposed by the statute on Medicare telehealth were the result of a lack of evidence around telehealth at the time. This was, of course, the late 1990s. And since 1834M was implemented, the impact of this statute on telehealth adoption and utilization has been very significant. With such little reimbursement for telehealth in Medicare historically, most entities who have been moving forward and adopting telehealth haven't even considered submitting claims or billing Medicare for these services. Therefore, the claims which have been submitted to Medicare represent far fewer than would have been if financial remuneration had been in place. And one can see the full impact of these policies here. Combining claims from both distant sites and originating sites, the total spending for telehealth in Medicare was a mere $28 million in 2016, just a small fraction of CMS's total Medicare budget of nearly $600 billion or $990 billion budget overall. This level of spending is nowhere near what the federal government anticipated spending when CBO scored the bill in 2001, and at the time estimated it would cost the Medicare program $150 million to cover telehealth services in just the first 5 years. That's $30 million a year. So without reimbursement, Medicare really isn't getting the picture of what's happening in telehealth, nor is it realizing the potential telehealth has to offer Medicare population. There's clearly a lot going on around telehealth, as we all know, but it's been off the radar for CMS. And this difference between actual use and potential use for telehealth, coupled with concerns for increasing healthcare expenditures, have been pushing a groundswell of support to expand access to telehealth for the Medicare population and to change how CMS reimburses for telehealth services. So in 2010, the Affordable Care Act was enacted, which established the Medicare Shared Savings Program that promotes accountability for patient population health through various types of accountable care organizations. And in 2015, there was MACRA, which replaced the Sustainable Growth Rate Physician Payment System with the Quality Payment Program, which became implemented in January of 2017. And this legislation provided new approaches to reining in healthcare spending through incentive and value-based payment models under its two tracks, the MIPS program, Merit-Based Incentive Payment System, which is the fee-for-service program with links to quality and performance, and the alternative payment models or the value-based care models. In addition, through CMS's Center for Innovation, new payment innovations could be implemented and tested. And then we also saw the 21st Century Cures Act get enacted in 2015, which also promoted the adoption of telehealth and digital tools. And of course, over the years, we've seen various telehealth bills get introduced each year, but these bills never gained enough traction to make it over the finish line. And then in 2017, in our current 115th Congress, we saw the momentum build on Capitol Hill as dozens and dozens of bipartisan Medicare telehealth bills were introduced in both the Senate and the House, all focused around expanding access and payment for telehealth. It was the Chronic Care Act that was the Senate's large healthcare bill, which focused on improving chronic disease management by expanding access to telehealth for acute stroke services, for patients with end-stage renal disease who are receiving home dialysis therapy, for use in accountable care organizations, and for enrollees in Medicare Advantage plans. And this large Senate bill passed in the full Senate in September by unanimous consent. Wow, this was a major milestone for telehealth, especially since it was one of the few healthcare bills the Senate was able to move at all last year. And the House was also very engaged in telehealth legislation, and the Chamber continued to advance a number of smaller, more focused Medicare telehealth bills, which aligned closely with the provisions in the chronic care package. On the House side, there was the FAST Act of 2017, which was introduced to address telestroke, and this bill passed in Energy and Commerce. There was the Medicare Part B Improvement Act of 2017, which addressed the provision of in-home telehealth for home dialysis patients, and this bill passed in the House. And finally, there was the Increasing Telehealth Access in Medicare Act, which addressed telehealth coverage under Medicare Advantage plans. And this bill also passed in House Ways and Means. And in November of last year, Tim Wright, our VP here at InTouch Health, and I went to Capitol Hill to advocate for telehealth payment reform and the passage of these bills. And we met with a number of congressional offices. We had meetings with Senator Schatz's office, Representatives Thompson, Matsui, Griffith, and Hudson. And we came away from our meetings with a sense that leaders were working very hard to reconcile what they said were small differences between the Senate and House bills, and they were feeling really optimistic that telehealth legislation would pass. In fact, members were already thinking about their next set of telehealth policy priorities. We also learned that leaders in the House plan to continue to bring forward more narrowly focused legislation as opposed to large bills like the Connect for Health Act because of the difficulty moving larger bills through the legislative process to passage. And after our meetings, we followed up with a letter campaign, also providing feedback on language in the bills. And we sent these letters to leadership of both chambers and to all of the committees with jurisdiction over telehealth, which is Senate Finance and House Energy and Commerce and Ways and Means. And then by early December, the three provisions from the Chronic Care Act were lined up with related bills in the House. And then the House dropped the ACO Improvement Act of 2017. And then all four provisions were in play and poised and ready for passage. And from our discussions with lawmakers, we were anticipating the telehealth bills would not pass individually, but rather the provisions would hitch a ride at the end of the year in the Medicare Extenders package. But with the tax bill and the government budget front and center as we approach the end of the year, Congress pushed Medicare legislation policies into 2018. There were also several other notable regulatory developments related to Medicare telehealth that occurred in late 2017 and into early 2018. Under the 2018 physician fee schedule, 7 new telehealth codes were added, which became eligible for payment on January the 1st this year. And the use of the GT modifier for claims made for professional telehealth services was eliminated. Also, under the 2018 physician's fee schedule, CMS unbundled CPT code 99091, allowing payment for remote patient monitoring for the first time. CMS also clarified that it does not consider remote patient monitoring to be telehealth, and by defining 99091 as a telehealth service, these services are not subject to the geographic location, technological, and other restrictions placed on telehealth services. In addition, more remote patient monitoring codes are anticipated for 2019. We know already that AMA has approved 3 codes, and these codes are currently going through the RVU process for payment. We will know more about these codes when CMS issues the 2019 physician fee schedule proposed rule this summer. In addition to Medicare telehealth initiatives, there are also other activities that highlight expanding interest around telehealth in the federal system. First, the VETS Act passed in both the Senate and the House, and this major piece of legislation expands access to telehealth for veterans and sets up a national licensure model for cross-state telehealth where VA providers can practice with one license when caring for veterans anywhere to anywhere. Then under the 21st Century Cures Act, the FDA released several guidance documents on regulating devices and digital tools, and MedPAC, which is Medicare's payment advisory group, is required to deliver its report to Congress with recommendations for Medicare payment reform around the use of telehealth in March. We also saw the FCC announce a boost for broadband funding, and we saw them repeal the net neutrality rules. Also, this past year, the national opioid crisis came into focus, and telehealth was emphasized as a critical tool that could be used in the fight against addiction. And this policy discussion also brought renewed vigor around the need to revise existing federal regulations in the use of telehealth and remote prescribing of controlled substances under the Ryan-Haight Act. And just last week, we heard that the House Energy and Commerce Committee is preparing a package of legislation to address these very issues. So we should be seeing that package coming out, I believe, around May. As you can see, we've been in this changing world of telehealth policy. There's a lot going on, and the momentum has really been building up on Capitol Hill, especially over just the last few months. And finally, the pendulum has swung, and Congress passed meaningful legislation expanding Medicare telehealth in the final budget package, which was signed into law on February the 9th. So just a few weeks ago, the Bipartisan Budget Act of 2018 was passed, and it included all 4 of the telehealth provisions that we discussed earlier. This first for getting a complete telehealth package across the finish line gives Medicare, the telehealth program in Medicare, a really huge boost forward. And it represents the very first time that physician payment has been enabled for the broad Medicare population beyond rural. So now let's go over some of the main takeaways of these provisions, which will be at a fairly high level at this point because the legislation doesn't go into a lot of details, and we'll need to see kind of what the rules come out with in a few months. But then we'll talk about some of the potential implications of these measures and these implications, what may have on you, your patients, and the telehealth industry at large. So first, let's talk about the telestroke provision. This provision goes into effect on January the 1st, 2019, so we're just about 10 months away. And in this provision, the bill removes the geographic rural restrictions for all hospitals, critical access hospitals, and for mobile stroke units. It adds mobile stroke units as eligible originating sites and also will allow the HHS Secretary to add additional originating sites in the future. The provision also enables the distant site practitioner to bill to get paid for telestroke consultations to originating sites in non-rural areas. And for this provision, newly defined originating sites will not be eligible to receive a facility fee. So for this provision, we can see that by eliminating the geographic restrictions, the new law expands access to these life-saving telestroke consultations to Medicare beneficiaries who have not been able to receive these benefits to date because they reside in urban areas. And the bill also significantly expands reimbursement opportunities for distant site providers delivering the telestroke services, who will now finally be able to bill for the professional fee for delivering consultations to patients anywhere in the United States. And with this new opportunity, the bill, we can see healthcare systems and providers will want to get their billing systems and processes in place to be ready and set to go when the rule goes into effect. In fact, opening up telestroke to more originating sites, including here at mobile stroke units, does create broader options for spoke hospitals too, who don't currently have access to stroke neurologists. And it also creates expanded opportunities for health systems with stroke programs to increase revenue and expand to new patients. This provision also may create, we see, some incentives for doctors which could help recruit and expand the pool of stroke neurologists, which is in short supply. The next provision is around end-stage renal disease and home dialysis. And these are for patients who are receiving in-home telehealth that we're talking about here. And this provision also goes into effect on January the 1st, 2019. The provision removes the geographic restrictions for approved originating sites, which includes hospital-based dialysis, critical access hospital-based dialysis, and standalone dialysis facilities, and the patient's home. The bill expands originating sites to include the patient's home and standalone dialysis facilities for the first time. The bill allows payment for monthly assessments via telehealth for these patients in the home and at other eligible originating sites after initial visits with the physician are conducted in person during the first 3 months of home dialysis, and then subsequently in person at least once every 3 consecutive months. This bill also allows the providers of services or the renal dialysis facility to give the telehealth technology to the dialysis patients for home use at no charge when certain conditions are met. Number one, the telehealth technologies cannot be part of any advertisement or solicitation, and the technologies are provided for the purpose of furnishing telehealth services related to the individual's end-stage renal disease. And, of course, the provision of the telehealth technology must also meet the other regulatory requirements as outlined by HHS in their rules. And finally, for this provision as well, there will be no facility fee when the home is the originating site. So now let's talk about the implications for this particular provision. By adding more sites of care here, the legislation again creates much broader and more convenient options for patients with end-stage renal disease, and in particular by enabling the care in the patient's home. The legislation also creates opportunities for nephrologists to expand their reach and their program size. And this is especially important as nephrologists are not evenly spread across the country and don't necessarily reflect the distribution of patients with kidney diseases. The bill here also expands reimbursement opportunities for telenephrology consultations beyond rural and for the first time into the patient's home and to standalone dialysis facilities. And finally, with the new legislation and expanding payment for professional nephrology services, we may now see more deployment of home dialysis therapy and consumer or patient-facing telehealth solutions now going into the home. Okay, the third provision, which addresses accountable care organizations and allowing these groups the ability to expand the use of telehealth, this begins January 1st of 2020. And in this provision, the bill removes geographic restrictions as well to allow more ACOs to have flexibility to deliver telehealth services to assigned beneficiaries who are located in urban areas now and also in the patient's home. And currently, only the next generation ACOs have this kind of flexibility. The bill also expands this flexibility to more two-sided risk ACOs. So again, it focuses in on the two-sided risk ACOs. So this primarily will include, in addition to the next generation ACOs, it'll be the Medicare Shared Savings Program, Tracks 2 and 3 ACOs, and we may see a few others added to the list. The bill also allows for fee-for-service ACO beneficiaries to prospectively select an ACO participating professional as their primary care provider, and similarly, the bill allows prospective assignment of beneficiaries to the ACO. And finally, ACOs may actually apply to establish an ACO beneficiary incentive program. And I think one of the key implications of this provision is that Medicare is trying to push the market towards these two-sided value-based payment models because these models can improve care delivery and generate the greatest savings. We know the ACO market is growing, and the legislation here creates more opportunities and more incentives for ACOs to use telehealth across the care continuum. And in this expanding environment, ACOs may then actively promote telehealth, which will help to accelerate the market. The beneficiary incentive program, I think, is also an exciting policy, given the prospects that ACOs can start paying patients to encourage them to get their primary care visits within a particular ACO, so the provider group then can better control and coordinate their care. I think this is a first opportunity for ACOs to begin doing this kind of benefit design. And by allowing more flexibility for ACOs to utilize telehealth, this also expands the role of data and business intelligence to help ACOs identify where telehealth can impact cost, quality of care, patient satisfaction, and other outcomes and metrics in order to meet their targeted benchmarks. And the last provision, Medicare Advantage. This provision also goes into effect starting January 1st, 2020. The Medicare Advantage provision increases the flexibility for plans, Medicare Advantage plans, to include additional telehealth services as a core benefit. It allows the HHS secretary to determine which telehealth services can become part of the core benefit package. The bill also indicates if the Medicare Advantage plan includes a telehealth service as a benefit, then it must also cover an in-person visit for the same benefit. And finally, the bill allows Medicare Advantage plans to create plans that are tailored to special needs populations. The implications of this provision are also far-reaching. The provision allows Medicare Advantage plans to include these additional telehealth benefits in their annual bid amounts, which creates a financial and a value-based incentive for Medicare Advantage plans to utilize more telehealth. Today, additional telehealth services, as you know, are included as supplemental benefits, and this has been a major reason why Medicare Advantage plans have not been as quick to cover telehealth services as other payers. And similar to ACOs, the new legislation is pushing the Medicare market in this direction towards value-based care, which again creates more opportunities and incentives to utilize telehealth across the care continuum. And along these lines, we may also see Medicare Advantage plans actively promote telehealth and adopt more patient-friendly types of plans. And under this provision, CMS is required to solicit public comments by November 30th of this year with respect to the types of additional telehealth services that should be considered and the requirements around these services. So this creates an opportunity, again, to provide feedback to CMS around which telehealth benefits should be included as core benefits for the Medicare population. Medicare Advantage enrollees under this legislation will have the option to receive these additional benefits through telehealth or in person. And for the special needs plans, the law permanently authorizes and strengthens the program, which will in turn encourage plan sponsors and other stakeholders to further invest in the program. And finally, this provision also creates opportunities for hospitals and providers to engage their Medicare Advantage plan partners to discuss expanding coverage for telehealth services. So given the evolving policy environment, let's now talk about the outlook for telehealth policy and where these policies may be headed in the future. At the federal level, with so many meaningful telehealth provisions in the new budget bill, I think we can say the door has finally been cracked open. And this is a clear sign there is strong bipartisan support and a willingness on the part of policymakers to work to expand and integrate Medicare telehealth into the healthcare system. I think we're going to continue to see more positive trends in the federal policy landscape for telehealth. We're going to see new policy priorities emerge, which will open up opportunities for all of us to help guide, educate, and advocate for needed changes that are going to bring our policies to be more closely aligned with where healthcare technology innovation already is today and where patients and consumers really want healthcare to go. In fact, lobbying groups are already engaged in these efforts to further expand federal telehealth reimbursement. We know the ATA and HIMSS have been strong advocates for the Connect for Health Act, H.R. 2556, which is a very large telehealth bill, but it would allow the HHS Secretary to waive certain restrictions for telehealth. The Alliance for Connected Care is advocating around the Evidence-Based Telehealth Expansion Act of 2017, H.R. 3482, which is a bill that's similar to the Connect, but it allows the Secretary, again, to waive restrictions for telehealth. CTEL is advocating for changes to the Ryan-Haight Act around prescribing controlled substances for telehealth. And just to name one more, Health IT Now is advocating around new legislation that would make it easier for nursing homes to be reimbursed for remote care. And I believe there's a bill right around the corner in the next couple of months that we'll see being introduced around that issue. And there's no doubt that with increased federal financial support from the budget bill, the opportunities for telehealth adoption and investments will only accelerate. And in particular, these value-based care models, I think, will continue to play a key role in healthcare transformation and continue to expand at the federal level. We know the shifting Medicare payment structure to value is well underway. Between 2016 and today, fee-for-service went from 46% down to 35% of Medicare's payments, as you can see here, with more than 50% of Medicare enrollees now in Medicare Advantage plans or Medicare ACOs and other value-based models. We have reached the tipping point, and we're clearly over the edge. And just last week, Medicare Advantage enrollment topped 21 million, adding more than 130,000 lives in February. And outside Medicare, we know Medicaid and commercial payments are moving rapidly to this model as well. I think it's a really exciting time for telehealth policy. And for the first time, the payment paradigm around digital health under Medicare is changing. But it's also very important to recognize there is still a lot of policy work that needs to be done. And in this changing legislative environment, advocacy at the federal level is going to continue to play a critical role to advance remedies to policy challenges and to help drive the option of telehealth. And this is something that I think we can each take part in, and many of you already, I'm sure, are involved in advocacy. But if you're new to this, I would encourage you to reach out to your legislators or the sponsors of telehealth bills and other leaders on the Hill. Go ahead and meet with them and talk with them about telehealth. They really appreciate hearing from constituents, and they can learn a lot from you. I think it's very important that healthcare systems, hospitals, providers, and the key stakeholders in telehealth get the message out to policymakers and advocate for telehealth, especially around where virtual health is going. This would be a great time to advocate on behalf of expanded telehealth coverage as well with your commercial and Medicaid plans because, as we know, they often follow Medicare and their reimbursement trends. At InTouch Health, our advocacy priorities have been about expanding payment more broadly for telehealth and eliminating barriers such as restrictions on geography and originating sites. Today, given the passage of the new legislation, we're also thinking about our next steps and ways we can help advance the legislative and regulatory environment to bring greater access to telehealth. We believe building alliances and advocating in partnership could help bring a more coordinated and a more powerful telehealth agenda to Capitol Hill, and we're very interested in opening up a dialogue with you and talking about areas of interest and areas of great need and what we can do by pulling together to advocate for policy changes. So if you share this interest and would like to talk about ways we can collaborate, I would love to hear from you. My email address is posted here, so please reach out to me with your contact information and let's continue the conversation. In closing, first I'd like to share with you just a few of my go-to resources that help me keep on the pulse of federal telehealth policy news and information. And I'd like to thank you for taking your time to join us today for this policy update. I know we have a few minutes now for Q&A, and I'll be joined by Tim Wright, our VP of Corporate Strategy and Business Development. Back to you, Rachel.
Thanks, Jordana. So we'll begin our Q&A session now. If you haven't yet gotten your questions in, feel free to enter those using the Q&A console. Tim Wright, VP of Strategy, will be joining us for the Q&A session in case you all hear another voice hop on the line. But Jordana, first question is, you mentioned dialysis and stroke are popular use cases in telehealth legislation. Are you aware of what other use cases might be coming next in the form of telehealth bills?
Great question. Yes, I think what we're going to be seeing are more high acuity care types of use cases. We may be seeing cases around more chronic disease management and behavioral health as well. I think, use cases where telehealth can certainly deliver high quality services and reduce costs, and where there's evidence around the particular use case, I think that's going to help propel it forward more quickly. But as I mentioned, we're seeing, we're hearing that there's going to be legislation coming out around, assisting with the opioid crisis, and I know CTEL's working on that. Work with the DEA to get the specials registration set up so that telemedicine can be used without the in-person visit to e-prescribe for controlled substances.
Great, thank you. Another question that came through is, my hospital system already does advocacy. Is this different?
Is this different? No, I think we're talking about the same kinds of advocacy. If we're talking about, talking with your legislators, pushing for telehealth policies, changes. It could also be talking with CMS to help, advance telehealth policies there. I think we're talking about the same thing, and really again, we'd love to, open up the dialogue with others and talk about where we have shared goals and how we can sort of work together to raise the industry.
Jordana, this is Tim. Mm-hmm. The other thought that comes to mind on this is the feedback that we got on the Hill. To some degree, the health systems are out there advocating pretty heavily with Congress, but frankly, their focus is on many, many things, and so their efforts are fairly diffused and perhaps not therefore as effective around telehealth. And so from that perspective, even though health systems are actively promoting legislation, they may not actually be focusing their time and energy on legislation which is directly relevant to telehealth. And so your health system may be very active, but may actually not be active with respect to these policies.
Great point, Tim. Mm-hmm.
All right. Another question is, how do you see the movement in the government acceptance of telemedicine impacting the private insurance reimbursement of similar services?
I think the commercial sector kind of watches to see what Medicare does, and I do think that the trends have been that they tend to follow Medicare policies. So I think this is going to help push some of those policies forward.
Okay. And then another one is, will reimbursement changes only begin after January 1st, 2019?
Yes, that is true. They will begin for the telestroke provision and the home dialysis provision starting in January of 2019. And then the following year, in January of 2020, the other two provisions, the ACOs and the Medicare Advantage Plan legislation will get implemented. So I think we can expect to see the proposed rules coming out most likely this summer. And again, CMS will be soliciting feedback on the telehealth services by November as well. So we should know more coming up in the next several months.
Okay. Are there limitations regarding use cases for ACOs and telehealth?
Limitations for use cases. I think the ACOs still need to meet the telehealth requirements that Medicare sets for services delivered by telehealth, but with the new legislation, they're going to be able to, if they're the two-sided risk ACO models, they're going to be able to deliver these services to the home and to locations, to patients who are located in urban areas. So I'm not familiar with any restrictions around particular use cases, but that's a good question, and it's something that we can certainly do some more research around.
Okay. And who can bill for this now that we have payment for telehealth?
Right. Well, in general, the legislation addresses payment for the telehealth consultant. So it's the distant site provider that we're talking about will now, for the first time, be able to bill the consult fee. Of course, the originating site will still be able to bill the facility fee, except for those few exceptions that we talked about earlier.
Great. We are starting a telemedicine service for neonatology. Who or what would be a good resource to discuss how we may be able to start billing for our telemedicine physician services?
Well, that's a great question, and I think, we have this person's contact information. We can certainly follow up and provide some resources and some names to help with all of that. I know, Tim, is there anything you'd want to add there? I know that's something that we're very familiar with.
Yeah, I think, maybe it's useful to share a little bit. So as we have spent time with the congressional staffers, I think there's a high degree of interest in sort of starting with, so stroke being a use case that's really easy to understand the value proposition. It's easy to see why telemedicine is making a big difference. There's lots of evidence in the market and in the research community around that. I think neonatology and other scenarios or use cases which are kind of life-threatening or are, where speed to access to a specialist makes a huge difference. Yeah, I think those kinds of use cases are gathering a lot of momentum on the Hill. And so, we should speak more specifically with this individual, but I think those are good ones to target for specific advocacy.
All right, another question is, can you help me understand the significance of dropping the GT modifier?
I think that, I'm sort of guessing here, but I think that CMS was just trying to unburden, make it a little bit less difficult to submit claims. And so I think they were just trying to make it administratively less burdensome. That's my understanding.
Yeah, there was a lot of pushback, over the years about having to specify, this unique modifier when the service is being provided via telemedicine. And so I think you're right, Jordana. This is all about starting to reduce the friction that's associated with doing it in a different way.
And we're seeing a lot of that, Tim. I think we're seeing more of this coming out of CMS, where they're trying to reduce the administrative burden for physicians and for others just in general. So I think it's kind of, something that they're working on across the board, and this is one of those areas.
All right. There seems to be a lot of legal action being filed against the FCC. Do you feel that the repeal of net neutrality will impact many of the current and pilot telehealth programs, and why?
Mm-hmm. Well, that's a compliment.
Yeah, wow. So I'll give it a stab, Tim. I think the whole net neutrality conversation is there's a lot of debate, a lot of robust debate on both sides about this particular issue. I'm certainly hoping that it doesn't end up hurting telemedicine and hurting especially those in rural areas. But I think, just sort of remains to be seen what's going to happen here. And I think we're going to need to have some more conversations about this. And I know in terms of the ISPs, there are new rules around transparency requirements and disclosing, if they're doing any throttling or blocking or, creating these tiered payment structures. I think, from the FCC side, they're thinking this is going to generate more competition and infrastructure and that kind of thing. But I think it just sort of remains to be seen what's going to happen. Tim, what are your thoughts around this?
Well, I think you're right. I think that I don't expect this to have any impact on telehealth in the near term. I think that over time you could imagine specific products being developed by the ISPs to target high resolution video as a use case, and perhaps charging a surcharge on that kind of a service. But I think it's a ways off, and there's a lot of other moving parts that could smooth any kind of impact those have. So, I don't think, at least at InTouch, I don't think we're concerned that it's going to impact the growth of telehealth programs.
Right. Why haven't MA plans been using telehealth to date if it can help them control costs?
Right. Well, I think they haven't had much of a financial incentive, I think, up to this point, which is what the legislation addresses. So currently, they're only required to provide benefits that are included in fee-for-service Part B, and anything beyond that goes into supplemental benefits and is not included in their annual bid. So they're not getting payment for it through the capitated payment from Medicare. So there hasn't been a whole lot of incentive, I think. Now that they'll be able to build those benefits and get paid for them from Medicare, into their core benefits, I think we're going to start to see them, start to promote telehealth more and start to use it more and to see the value of it.
I think there's also, that's a great answer, Jordana. I think there's also an element to this, which is, there's some anytime you're providing care for a Medicare beneficiary, you're concerned about any sort of legal, constraints or just not being consistent with Medicare overall policy, whether that's, anti-kickback or other things. And so to the extent that Medicare was discouraging, telehealth in non-rural locations, if you're a Medicare Advantage plan, you sort of start with adopting the Medicare rules and then go from there. And so I think this legislation says, hey, it's okay for you to go to it, use telehealth. So it gives them permission to be more aggressive and think more boldly about the use of telehealth as a way to provide care. And I think that there was another question that had come across around, why you can't advertise, why they had put this provision against advertising, and that's the same sort of thing. It has to do with, that smells a little bit like it could be an anti-kickback or could run into an anti-kickback issue, and so this is all about navigating all the different Medicare limitations that are out there.
Okay, another question we have is, will changes in the telehealth policies also affect credentialing of physicians across state lines, and when do you expect that to change?
Mm-hmm. Wow, the credentialing issue. I'm not seeing anything come forward about changes that would occur there with regard to credentialing. How about you, Tim? Are you seeing anything along those lines?
No, I don't. I mean, I think that's a separate and also important policy issue. And so licensure and credentialing are both big barriers to sort of the broad adoption of telehealth, and we haven't really seen a lot of movement, I don't think, on either of those, have we, Jordana?
No, I haven't seen anything. Of course, there's the credentialing by proxy, and no, I haven't seen anything.
Okay. Another question is, do you favor payment parity as it just passed in Kansas? It seems like it will reduce the ability of telemedicine to compete and the ability of telemedicine to cut costs.
I'm sorry, can you read that one again, Rachel?
Sure. Do you favor payment parity as it just passed in Kansas? Mm-hmm. It seems like it will reduce the ability of telemedicine to compete and the ability of telemedicine to cut costs.
Yeah, I don't have a point of view on that. I don't.
Yeah.
Go
ahead. No, please, go ahead, Tim.
No, I don't. I don't know, and sort of, we start opening up the state-by-state dialogue, and every state has a very unique, legislative landscape, and so, but I don't have a position on payment parity, and I don't think it's likely to get any movement, to be honest.
Okay, and one more question. Where are some resources we can go to for help in contacting our representatives for telehealth advocacy?
Great question. So you can go to www.congress.gov, and you can find look-up tools there for all the senators and all the representatives. You can actually even, look up everything about a particular bill. You can set alerts for particular bills if you have an interest around getting that kind of thing. So that's been a resource for me, and so it's also listed on the resources slide towards the end of my presentation.
All right, so we're coming toward the end of the webinar. There are some questions that we haven't gotten to yet. We will respond to those through email after the webinar. And thank you everyone for interacting and providing these questions for us. We would like to give a big thank you to Jordana and Tim for the presentation today. For any additional questions or information, feel free to contact us at feedback@intouchhealth.com or contact us directly through Jordana's email, which was on her resources slide as well. This webinar will be recorded and available within the next 48 hours with the slides, so please keep an eye out for that in your email. That concludes today's webinar, and thank you all for your time and have a great day.